In 2022, the CDC found that nearly 42% of Americans can be classified as obese. Obese meaning that their adult body mass index, or BMI, is higher than 30. Obesity by itself is responsible for up to 14 years of lost life expectancy, mostly through cardiovascular disease. And the United States spends nearly $200 billion a year treating the diseases and other health issues relating to obesity. These costs are projected to rise in the near future. The easiest way to treat obesity is through changes in lifestyle and behavior. However, this often does not produce significant or lasting weight loss. The most effective intervention is bariatric surgery, directly making changes to the digestive system. However, these come with all the complications of any surgery. In between these two axes, we have pharmacology, weight loss drugs. However, the history of weight loss medication is long and full of missteps and failed claims. In this video, we're going to look at the long and difficult history of weight loss drugs before Ozempic. Doctors have known obesity to be a problem since the days of antiquity. For instance, we have the writings of a 2nd century Greek doctor named Soranus of Ephesus. He describes the issues of obesity and prescribes exercise, heat, and massage, plus laxatives and purgatives. Yes, vomiting. Roman doctors regularly recommended that obese individuals vomit in the middle of the day, taking a mixture of vinegar, salt, water, and half a cup of hyssop plant. In 956, Sancho I, unfortunately named Sancho the Fat, became a king of Leon, a historical northwestern region of the Iberian Peninsula. But after 2 years, he was overthrown. The nobles did not respect him because he was too obese. After trying many remedies, Sancho's grandmother finally went to a brilliant Jewish physician in Cordoba named Hasdai ibn Shaprut. Shaprut gave Sancho a treatment called theracia. Theracia dates back to the 1st century and has 64 ingredients, but the primary stuff was opium, ginger, cinnamon, myrrh, saffron, and castor oil, a laxative. It worked. Sancho lost enough weight to ride a horse and returned to retake the throne. 1,000 years later, Sancho took his rightful place on the Tennessee band Kings of Leon and delivered the chart-topping single Sex on Fire. As our understanding of the body and its anatomy progressed, we were able to introduce new treatments based on that understanding, and thus we come to the 1880s and some of the first science-based treatments for obesity. People become obese when they eat more calories than they burn. Therefore, a weight loss drug reverses the obesity by making you do the opposite, eating less calories than you burn. There are 3 general mechanisms by which said drugs can achieve this. 1. A drug might try to suppress your appetite. In doing so, the person eats less on a daily basis, creating a caloric deficit that causes the body to burn fat. Many of the weight loss drugs mentioned here try this approach, often by modifying the release or reabsorption of certain neurotransmitters in the brain. Second, a drug might try to increase energy expenditure. By raising your metabolism, the body consumes more energy, creating a caloric deficit that burns fat. Caffeine or ephedrine do something kind of like this, though they aren't approved as weight loss drugs. There is also another drug we will discuss later that does this too. Or 3, a drug might try to interfere with the digestive system's ability to ingest and take up fat from the food you eat. The history of weight loss drugs over the past century or so is long and full of complicated words I will inevitably fail to correctly pronounce, but keep in mind that they all basically work in one of these 3 ways. In the late 19th century, growing industrialization and its changes in lifestyle created new demand for weight loss drugs. It had been known for a while now that the thyroid gland can increase or decrease metabolic rate. Doctors studying a form of hypothyroidism, a failure of the thyroid, noticed a variety of symptoms, including a puffy weight gain. When treated with sheep-derived thyroid extracts, those symptoms, including the weight gain, went away. By the early 1890s, clinical reports on using an extract of the T3 thyroid hormone for obesity began appearing. Doctors started using thyroid extract to treat obesity, but were limited by its drawbacks. These are similar to the symptoms of hyperthyroidism and include abnormal heart rhythm, dangerously high heart rate, and possible heart failure. This century was a time of quack medicines claiming to cure cancer, syphilis, gout, hepatitis, the whole lot. They rode on the growing newspaper and cheap bulk mail industries, promising curative powers to people and preying on their naivety. These medicines had entertaining names like Allen's Anti-Fat, Frank J. Kellogg's Safe Fat Reducer, Marmola, Newman's Obesity Cure, Dr. Gordon's Elegant Pill, and so on. Despite the variety, almost all of these quack medicines were made from similar ingredients, some combo of thyroid extract, vomiting-inducing agent, an appetite suppressant, a diuretic, or a stimulant. In response, the U.S. Congress passed the Pure Food and Drug Act of 1906, which was supposed to allow the FDA to go after adulterated or misbranded food or drugs. However, in 1911, the U.S. Supreme Court diluted the act's effects in the case United States versus Johnson. The Johnson, in this case, was selling Dr. Johnson's mild combination treatment for cancer, which, not so mildly, claimed to cure almost any cancer. The Supreme Court ruled that the act only addressed false claims about the ingredients inside the product, not its potential therapeutic effects. That is because disease cures are often a matter of uncertainty and conflicting medical opinions. So the next year, Congress passed the Sherley Amendment to ban misbranding claims on drug labels. The Supreme Court promptly ruled again that these claims not only had to be false, but also fraudulent. The end result was a loophole that would last for 50 years, hobbling efforts by the FDA to cut down on these quack medicines. In 1933, Dr. Maurice Tainter at Stanford reported on the weight-lowering properties of 2,4-dinitrophenol, which I shall thankfully call DNP. DNP is used to make explosives, and it itself explodes too. We also use it as a sulfur dye, wood preservative, photographic developer, and herbicide. How did Dr. Tainter at Stanford, always those Stanford doctors making trouble, notice that an herbicide happened to cause you to lose weight? He had been studying cases of accidental DNP exposure by French soldiers during World War I. Workers at the French factories producing the stuff had also been claiming that they grew thin after several months working there. Dr. Tainter's experiments were done with razor-thin margins, since DNP is so toxic. But he eventually found that if you take a daily dose of about 3 to 5 milligrams per kilogram of initial weight, you can lose about 1.5 kilograms per week. The initial side effects were skin rashes and neuritis, which seemed okay at first, but it would not be until later that other more serious conditions, like cataracts, were discovered. How does it work? Well, let us go to the mitochondria. The mitochondria is the powerhouse of the cell, producing the ATP where cells get their energy. DNP moves protons across membranes, allowing protons to leak through the mitochondria's inner membrane. This interferes with normal ATP energy production and makes it less efficient. This extra energy is wasted as heat. By throwing a wrench into the energy generation process, the body is forced into a calorie deficit and has to dip into fat reserves. The downside, of course, is that DNP's heat generation effect can seriously overheat the body, causing hyperthermia and tachycardia. Throw in the fact that DNP is a freaking herbicide, and we have substantial risk of fatal intoxication after repeated administrations. Despite these very real risks, there was tremendous interest in DNP right at the start. Stanford Clinic supplied over 1.2 million DNP capsules to patients, and over 100,000 people took them. Many were affected by the side effects. In 1935, the FDA issued a note of concern, but did not have the authority to regulate medicines and keep DNP off the market. That changed in 1937 with the elixir sulfonamide crisis. Sulfonamide was a new antibiotic for venereal disease and sore throats. A manufacturer added raspberry flavoring and a chemical called diethylene glycol to turn the hard-to-swallow pills into a pleasant-tasting liquid for children. Today, We use diethylene glycol to make solvents, plasticizers, and antifreeze. They gave children antifreeze, and 100 of them died slowly and painfully from irreversible liver failure. After a frantic federal investigation, Congress passed the Federal Food, Drug, and Cosmetic Act of 1938. Now, with the authority and facing over 2,500 reports of DNP-induced cataracts, the FDA removed DNP off the shelves. DNP later showed up again in the 1980s when a physician in Texas started to make and sell it himself. It is still sold online under names I shall not mention, mostly for bodybuilders. Amphetamines cause the rapid release of chemicals like dopamine into the brain. This not only gives the user a rush of energy, but also increases their metabolic rate. A higher metabolic rate often leads to weight loss. These amphetamines truly have a dark and light side. On one hand, there are real uses for them, like for reducing sleepiness and narcolepsy. On the other hand, the way they release this intense rush of neurotransmitters can easily cause addiction and negative social behaviors. In 1933, an American pharmaceutical company called Smith, Kline, and French started selling an amphetamine called Benzedrine as a decongestant. 2 years later, a pair of doctors at UC San Francisco did a study using this amphetamine to treat narcolepsy. They noted that the patients also lost weight. Another amphetamine study for psychiatric issues noted the same. Smith thought about marketing its amphetamine drug as a weight loss agent, but worried that doing so would taint its reputation as a reputable psychiatric drug. However, by then, wildcat companies were already selling it for that purpose, and then widespread use by the end of World War II pushed Smith to move beyond these concerns. In 1947, the FDA approved the use of methamphetamine desoxyephedrine for the treatment of obesity. 3 daily doses of 2 milligrams could lose up to 25 kilograms of weight, the major problem being that they are insanely addictive. And now we come to the infamous rainbow pills. In 1941, a pharmaceutical company called Clark & Clark started producing diet pills made from amphetamine sulfate, thyroid hormone, and other things. A simple combination that did not break any new ground in weight loss drug chemistry. Clark called them Clarkatabs. However, their wide range of fun colors, which gave the mistaken impression of personalized treatment, branded them as, quote, rainbow pills. These would be very popular over the next 2 decades. Rainbow pill firms sold directly to physicians who sold them to patients, cutting pharmacies out of the loop. By 1967, there were about 5,000 doctors and 2,000 practices in this business, earning $250 million in fees and another $125 million in pills. And all this was somehow legal, albeit acknowledged by industry professionals to be of low ethics. Internally, the FDA struggled over whether it should take action. For one thing, these rainbow pills slipped through loopholes in the system. The 1938 Food, Drug, and Cosmetic Act mostly concerned labeling and grandfathered drugs that were already in the market at the time of passing. Furthermore, the rainbow pills' ingredients were already approved for other therapeutic uses at the time. Furthermore, there was little evidence at the time about whether or not these rainbow pills were actually hurting people. Any expert the FDA might bring up to testify about the pills' downside, the companies can bring their own experts to counter-testify and poke holes into the argument. The FDA was also hesitant to interfere with how the doctors did their job, and the rainbow pills' firms made so much money and marketed so aggressively. Taking away the punch bowl in the party risked significant blowback. As it turns out, the rainbow pill dangers had indeed gotten out of control, but it took major events outside of the FDA to move them towards action. First, a major piece in Life magazine in 1968. A reporter without medical necessity to lose weight went to 10 weight loss clinics and was prescribed over 1,500 pills. Then, a Senate subcommittee investigation identified over 60 deaths from rainbow pills. They launched hearings into the industry and added a series of amendments to give the FDA more regulatory authority over drugs, allowing the FDA to take more aggressive action. Starting in January 1968, the FDA seized over 43 million tablets from a dozen manufacturers for false and misleading statements on their labels. In the 1970s, the FDA reconsidered amphetamines and its cohorts for use in weight loss entirely. So, we all agreed that the amphetamines themselves were too addictive for wide usage. But can it be possible to create something similar without the addictiveness? Throughout the 1950s, the industry and the FDA explored a series of what we call amphetamine congeners, chemicals similar in structure and mechanism to the amphetamines. These didn't always turn out well. Take phenamethrazine, approved in 1956 and released to the market as Preludin. It is less excitable than amphetamines, but it was eventually discovered that it too can be very addictive. When chronically used, Preludin can cause delusions and paranoia, which to me seems like a side effect rather worth mentioning. It got very popular in the 1950s as a weight loss drug before being withdrawn. Many of these amphetamine analogs, even those that haven't been pulled from the market for safety reasons, ended up falling out of use anyway, with one major exception. Phentermine. It was first approved in 1959 and is prescribed in combination with exercise and diet as a short-term aid for weight loss. Today, phentermine is one of the most commonly prescribed weight loss medicines in the United States, with over 3 million prescriptions and 75% market share of the U.S. anti-obesity market in 2019. This is because it is widely available as a cheap generic drug, and per randomized short-term clinical trials it seems to work, but only over the first 12 weeks. Beyond that, it's probably run its course, and the side effects can get dodgy. Serious complications associated with long-term use include palpitations and tachycardia. Phentermine makes up one half of another infamous chapter in the history of weight loss pharmacology, Fen-Phen. Fen-Phen's rise and fall was spectacular. The meat of the story takes place in the 1990s, but its seeds were planted nearly 30 years earlier with a different drug called Aminorex. Another amphetamine-like drug that suppressed your appetite, Aminorex was developed by an American pharmaceutical company called McNeil and first sold into Germany, Austria, and Switzerland as the over-the-counter drug Menacil. But soon after its introduction, people noticed a tenfold increase in cases of primary pulmonary hypertension, or PPH, within those three countries. This is a rare condition, usually occurring in 1 out of every 1 to 2 million people, and it is where the blood vessels inside the lung narrow, raising blood pressure within the pulmonary arteries to dangerously high levels. Without treatment, the condition can progress and become fatal. In one Swiss study, 71 people were admitted to the hospital, 34 eventually died from it. Despite strong numerical evidence connecting Aminorex to this PPH epidemic, scientists were not able to replicate it in animals. But after the authorities pulled the drug in 1972, the epidemic ended. In 1973, phenfluramine hit the market. Like all the other drugs that we have talked about so far here, phenfluramine is an amphetamine congener, which means it looks similar to amphetamine, but interestingly, it worked quite differently. Phenfluramine's key mechanism was that it helps release more serotonin inside your brain, increasing feelings of fullness and suppressing appetite. Trials found that it was non-addictive and did not affect motor activity. It was first developed in the 1960s in France and was available there in 1964. The United States approved it for weight loss in 1973. Then in 1981, we saw our first report connecting phenfluramine to PPH, 2 cases similar to that with Aminorex. But it wasn't a big deal, mostly because of the fact that not a lot of people were taking it, and that is because phenfluramine by itself did not work that well. People who lost the weight could not keep it off. But in 1979, Dr. Michael Weintraub at the University of Rochester had the idea of combining phenfluramine with phentermine. The 2 drugs work differently to help you lose weight, so he reckoned that perhaps their weight loss effects might last longer and their side effects minimized when taken together. He ran a 28-week pilot study which found that the phenfluramine and phentermine combo, ingeniously shortened to Fen-Phen, worked together fantastically. Importantly, the patients who lost weight had significantly fewer complaints of adverse side effects than if they had taken just one of the weight loss drugs. NIH funded a longer-term study which then found that by week 34, patients taking the combo lost an average of 15.9% of their initial weight, 14 kilograms or 30 pounds, versus placebo, who lost 4.9% of their weight. Note that they also exercised and ate a healthy diet. It took some time for a reputable journal to accept the study, but in 1992, the journal Clinical Pharmacology and Therapeutics accepted it. The publication blew the doors down on a Fen-Phen craze. Fen-Phen went viral. Patients were calling doctors, demanding the meds for any price. As I mentioned, Phentermine was already a leading weight loss drug in the United States. In 1991, it was mentioned 1 million times in prescriptions. By 1995, that had rose to 2.3 million, and then a staggering 5 million the year after that, 1996. Fenfluramine's growth was equally mind-blowing. As late as 1994, it was mentioned about 100,000 times in prescriptions. Not a lot. That soared to 800,000 mentions in 1995 and 3.8 million in 1996. Entire practices were devoted just to dispensing Fen-Phen. As the craze developed, pharmaceutical companies wanted to market a more specifically acting variant of fenfluramine called dexfenfluramine. When the FDA gathered to discuss dexfenfluramine's approval in September 1995, they were aware of its connection to PPH. They knew that it raised its risk maybe about 10 times, but also acknowledged that PPH was usually extraordinarily rare. In the first vote, the FDA voted 5-3 to reject the drug, but one of the 3 supporters on the board made an impassioned plea to pass the drug, citing the dangers of the growing obesity epidemic. Weighing this seemingly rare PPH condition against the well-known and widespread downsides of obesity, the FDA held another vote and passed it 6-5. Upon approval in April 1996, the FDA took care to mention several cautionary issues, like the fact that the data for its studies only lasted a single year. But yeah, sure, nobody heard that. Dexfenfluramine hit the shelves in June 1996 under the trade name Redux, along with a massive advertising blitz and hype cycle. In the 5 months after its release, dexfenfluramine sold 1.2 million prescriptions right off the bat. It was never intended for fenfluramine and phentermine to be taken together. When pulling the combo together, Weintraub and his team basically assumed that since these drugs had been on the market for over a decade, that the safety kinks were all worked out. In that first long-term study, the most widely reported adverse effect was dry mouth. And previously, nobody had ever seen a case of an orally taken drug to affect a person's heart valves. Well, except for those involved in the Aminorex recall. All the way back in December 1994, 2 echocardiography technicians at Merit Care Health System in Fargo, North Dakota, noticed heart valve abnormalities in 2 women taking Fen-Phen. Over the next 2 years, they tracked it. It was still quite rare, about once a month, but it did seem to always be connected to Fen-Phen. In February 1997, a Merit Care cardiologist called the Mayo Clinic to compare notes. They collaborated on an article covering 5 cases. They then submitted this article to the prestigious New England Journal of Medicine for publication. The journal initially rejected it, asking for more data. In June 1997, they submitted another article with another 19 cases for a total of 24, and this was accepted. The article details a high incidence of lesions on the valves of the heart in women who took Fen-Phen for 5 to 19 months. As it turns out, fenfluramine stimulates serotonin release, activating serotonin receptors on the heart valves. These receptors stimulate growth of proteins on the flaps of tissue in the heart valves called leaflets. These leaflets open and close many times to let blood through without leakage and backflow, so they have to be thin and pliable. So when we stimulate that protein growth on the valves, it makes them thick. The thickened valve doesn't close properly and becomes leaky, causing something called blood regurgitation. Blood flows backwards, forcing the heart to work harder. Eventually, cardiac damage happens. Considering the importance of the information in the study, in July 1997, the journal, Mayo Clinic, and FDA announced the results in a joint press release. A few months later, in September 1997, Fen-Phen's producer, American Home Products, now part of Pfizer, was pulled from the market. 9,000 lawsuits were filed against American Home Products, which eventually had to pay $3.75 billion to settle the cases. Fen-Phen was a spectacular failure, but it was far from the only one in recent years since. You know how marijuana gives you the munchies? Tetrahydrocannabinol, or THC, the active ingredient in marijuana that gets you high, is known to stimulate food intake. So drugs were developed to block one of these cannabinoid receptors, CB1R, so to suppress appetite. The first drug was rimonabant. Developed by Sanofi Aventis in 2006, it was found to reduce intake of high-fat foods in rats. The rats lost 21% of their weight. So they ran a 2-year human trial in Europe. That trial found that a high dosage of rimonabant helped them lose about 8.6 kilograms. Sounds like a lot, but the placebo did about 2 to 3 kilograms, so really about 5 to 6 incremental kilos lost. Europe approved the drug and it hit the market as Acomplia, but the US FDA held off from approval. This was because the trials implied that the drug caused depressive disorders in about 10% of people. 1% of them even felt thoughts of serious self-harm. Only a year after the drug hit the market, reports started popping up about serious psychiatric problems, and the drug was eventually withdrawn from Europe in 2009. In the 1980s, a company called Boots Pharmaceutical in the UK was looking for drugs to treat depression. One of the drugs, sibutramine, was noticed to cause weight loss. So in 1988, they commissioned a small 8-week clinical trial with promising results. In the larger 2-year trial that followed, sibutramine cut weight by 12% after 6 months. This drug is another appetite suppressant. By blocking the body's reabsorption of 3 types of neurotransmitters, norepinephrine, serotonin, and dopamine, it leaves higher levels of them in the body, and thus we have more feelings of fullness. But unfortunately, the drug also caused higher than normal blood pressure and heart rate. The US FDA approved the drug in 1997 for weight loss, but the European regulator asked that the drug maker run yet another study about the higher heart risks. So from 2003 to 2005, they ran a large randomized study called SCOUT. With the study going, the EU approved it for marketing in 1999. SCOUT enrolled over 10,000 obese individuals and investigated whether the drug impacted the risk for cardiovascular complications. Unfortunately, it did, with 11.4% experiencing such a complication as compared to 10% in the placebo group. There were some issues with SCOUT. For instance, it only enrolled high-risk patients. The patients also kept taking the drug even after it was clear that they weren't losing weight, sometimes for even up to 6 years. No responsible physician would ever allow that. Nevertheless, the results were sufficient. The European Medicines Agency and the US FDA pressured Abbott, who eventually bought the drug after it bounced around a bit, to pull it. And in October 2010, they did so. The growing obesity epidemic desperately needs a good solution. But the history of weight loss drugs has stretched for over a century now and is full of high-profile setbacks. From thyroid to DNP to Fen-Phen, many of these drugs have seen incredible hype and hope, only to be withdrawn after new problems are discovered, oftentimes many years later. Furthermore, we must also confront the reality that most of the drugs we have today have humble effects on your weight, maybe an additional 4 to 6 kilograms after 6 to 12 months versus placebo. Patients enter the therapy with unrealistic expectations of how much weight loss they can actually produce. When progress doesn't go as far as expected, it gets disheartening, and they discontinue. Now we have this new category of drugs, the glucagon-like peptide-1 agonists, or GLP-1s. I'll cover them in more detail down the line. They seem to be game changers, but the history has long been full of these false promises. We should be cautious. Alright, that's it for tonight. Thanks for watching. Subscribe to the channel, send me an email. I love reading your emails. And I'll see you guys next time.